Right, and you stopped sharing, Jacob. Thank you very much. I'll share again. So, right. So the last part of the lectures will be around whole body MRI, and the main presenter will be Marie Wetterslev, who has been working with this for some time now, but I will start off giving the background and just saying that the attraction of whole body MRI, why is it potentially interesting? That is that not the least in psoriatic arthritis and spondyloarthritis, there is very diverse manifestations clinically and imaging wise from both peripheral and actual joints and incisors. And we know that MRI allows assessment of inflammation in joints and incisors, but also that conventional MRI only allows us to assess a very limited anatomical area at one examination, for instance, a knee or a hand. We also know that modern MRI scanners permit whole body MRI within less than 1 hour. But we should also remember that when we go, when you look at the results later, that the image quality that we see in whole body MRI is lower than conventional MRI because you don't have the same coils, the same receivers, and so the image quality is lower both due to the coils and also due to the fact that the resolution of the images is lower. Then also the images that we've had for these exercises, we had to use what we had, and that was generally not new images on the best machines, but some that were some years old. And therefore what we are doing today and what we're showing you is poorer than what we can do with the best possible machines that we will do if we started a study tomorrow. But we started off working with whole body MRI some years ago, actually 4 years ago, where image quality were definitely more an issue than now. We did 2 studies, and particularly Simon Krabbe in his study, where a scoring system was developed at OMERACT and presented 2 years ago. We had developed a scoring system which looks at peripheral joints and incisors in these many different regions, both in the shoulder and anterior chest wall, in the hands, in the hip region, but not only the hip, and that's important to say for what we're going to do today, where it's not only the hip that we score with this system, it's also, for instance, enthesitis at the greater trochanter. For the knee, the same thing, and for the feet. And we achieved quite good agreement, and it's been shown in several studies that it is a responsive method that can discriminate between, for instance, a TNF and a placebo treatment even within 6 to 10 weeks. In patient population of around 50 totally. So it is a sensitive measure, but we also knew that the next step would be to try to look not into the whole score of all these different regions, but into the more regional areas and see what we could do best there. So therefore we, as a next step, looked at this modular whole body MRI, where we use whole body MRI images, but only score certain areas. And we did a assessment of the knee region for one thing, and in the hip region as the other thing. And that's what we're going to present to you. That we used 2 different methods. First of all, the one that was part of the large study of the large scoring system for whole body MRI, which we called WIPE, or OMERACT MRI WIPE. And there it was semi-quantitative scoring from 0 to 3 in each of the different areas you see here, 1 for bone marrow edema and 1 for soft tissue inflammation. So we had a 2-component assessment, both for joints and for incisors. In the current study here, we then defined which area we should look at, which would be within 1 centimeter of the attachment, both regarding soft tissue inflammation and osteitis. So this is the hip module, and we had a similar knee module, identical to the one we published a couple of years ago. And again, here all the pathologies are scored from 0 to 3. But again, for instance, the knee synovitis or effusion, that is only scored in one area per region, per knee. So it is a quite rough 0 to 3 scoring system. In contrast, we also been working on making an atlas, but we're not finalized with that. But I just wanted to show you that we're working on that, and that of course, then we compare with the Himmeris-Kimmeris method that Walter and Jacob described. They are not looking at the trochanter, so it's not the same things we're looking at. They are complementary, not you could say competing. If we go into Himmeris and Kimmeris, I won't go more into this because it's already been described by Walter and Jacob. But it is this more granular semi-quantitative assessment of the bone marrow edema in the femoral head and also in the acetabulum in the hips, and in the knees it's in the femoral condyles and in the tibial plateau, and also in the patella. It was developed for osteoarthritis. Now we are applying it for these SPA patients. So, and this has already been shown. We look at, click areas with bone marrow edema in the femoral head and acetabulum in each slice. And the same is true in the knee joint, where you fit the overlay and then click afterwards and get a volume from that. A new thing, or not a new thing here, but we also scored synovitis and effusion, and that was done for the hip in the same way as it's been done in Himmeris also for OA, where you measure the thickness in the different in the perpendicular area to a particular direction compared to the main axis of the effusion. And then we developed a modified version of the knee synovitis and effusion measuring compared to the usual Kimmeris, where we used only sagittal images, and in each slide, each slice, which as you see are many, looked at the main thickness of this synovitis and effusion in the perpendicular direction to the main axis. So we, for instance, look here, take it here or measure here, so one in each slice, and then that is converted into a score which is added. So from here now, Marie will take over and explain what we did. So I'll stop sharing my screen and let Marie share hers.
Yes, thank you very much for letting me present today these results. Okay. From January to September 2020, we did 4 web-based multi-reader exercises, 2 cross-sectional and 2 longitudinal. In between, we had 6 web access to discuss cases and train inexperienced readers and to identify potential pitfalls. Available, we had this online calibration module for Himmeris. We had a PowerPoint with instructions for WIPE. At the 2 last meetings, reference images for WIPE were discussed to obtain consensus, and some WIPE reference images were available before exercise 4. Today, we will only present data from exercise 3 and 4, both exercises with longitudinal data, and both exercises involve patients with spondyloarthritis and psoriatic arthritis, mostly males with a mean age around 45. The images were read by 9 readers, 2 radiologists and 7 rheumatologists. Images were primary T1 weighted and STIR images, coronal hip and sagittal knee images. For 10 knees, we only had T1 weighted fat saturated post-contrast images. And the readers were blinded for chronology. The specific aims for 2 methods for assessment of inflammation in the hip, which would be Himmeris and WIPE, respectively the knee, which would be Kimmeris and WIPE region, to evaluate inter-reader agreement for status and change, sensitivity to change, and correlation between the 2 methods. And now to the knee results. This table shows only data from exercise 3, single measured ICCs with absolute agreement. Status scores are highlighted, ranging from, I can't see the last one, but they were mostly moderate, changes were poorer, and status scores were best for bone marrow edema. Here, status scores for exercise 4 also highlighted, almost comparable, but maybe poorer, and mainly because of less BME lesions in patients in exercise 4. Here we have one of the ICC tables. This one is for Kimmer's bone marrow edema. Lower left, you find status ICCs, and upper right, mean change ICCs. As you can see, there's a high variation between reader pairs. Therefore, we choose to calculate the agreement for the overall best 3 readers in the previous exercise. And then it looks like this. And as you can see, the values are markedly higher when you look at the status mean and change mean. This table shows only data from exercise 4, from 9 and 3 readers respectively. Highlighted status for 3 readers, and status scores were mostly moderate to excellent, ranging from 0.48 to 0.91. As you can see, values are markedly higher when only looking at these 3 readers. And this especially for effusion, and also when you're looking at change, the effusions are the effusion ICCs are excellent. Effusion change ICCs are excellent when you're only looking at in the 3 readers. And this is results regarding responsiveness. Wilcoxon test between time point A and B showed a significant change for both WIPE and Kimmer's knee effusion, and not for bone marrow edema. When looking at standardized response mean, it was moderate for effusion variables in both methods. The 2 methods showed good correlation, except for bone marrow edema change, showed here. And this in spite that they do not measure the same. For instance, soft tissue inflammation is measured in WIPE total and not in Kimmer's, as Mikkel told before. And now to the hip results. Again, this table shows only ICCs from results from exercise 3 from 9 readers. ICC for status scores are highlighted, ranging from 0.52 to 0.84. Change looks poorer. This table shows exercise 3 and exercise 4 results for the 9 readers. And status scores are highlighted. Generally, you could say they look a little bit poorer for exercise 4. This may relate to that there's quite minimal pathologies in many of the patients, and maybe especially in exercise 4. Again, we have this ICC table example. This is for Kimmer's effusion, and again, there's a huge variation. When looking at 3 readers, the 3 best readers overall from exercise 3, ICC means improve, both for status and change. Therefore, again, we looked at exercise 4 for only 3 readers. Status scores status scores improved. Effusion works well, but the ICC are still poor for bone marrow edema. And it's similar for change. Effusion works, again, good. And to results regarding responsiveness, Wilcoxon tests between the two time points showed a significant difference for wipe total and bone marrow edema. Standardized response mean moderate to large for these two variables. For HIMRIS and wipe, status scores and diffusion chains correlated good. So to sum up, you can say for knees, moderate to excellent agreement for status and change, numerically highest for knees synovitis effusion. And for hip, we saw moderate to good agreement for status, generally poorer for change. Agreement for some variables, numerically higher for most granular method, that is HIMRIS, but more time consuming. Between method correlation, moderate to excellent, although wipe and HIMRIS do not measure the same. High experience, increased agreement. The two methods seem sensitive to change, but patient material far from optimal. Hip region and knee region assessment by whole body MRI images is an important part of whole body MRI assessment of the entire body.
Great.
Yeah.
Great. Thank you very much, Marie. We are opening up for questions and comments from all of you. I think, Charles, you're pointing.
Yeah, I just have a question. I don't know if we discussed this before in general, and maybe it applies to this as well, but how about differentiating bursitis from enthesitis? I mean, and the examples that you showed in the hip there, I think there was some trochanteric bursitis on a couple of those. They can be related, you know, but how do we deal with that in the whole body?
In this system, it's not separated. It's soft tissue inflammation at the incisional region.
Yeah, that's the way we just, okay. Do you think it matters?
I don't know. I think that it has to be, with image quality we have, it needs to be fairly simple. We could definitely make it as we did when we performed the HIMRIS, the heel enthesitis system, where it was more granular than just soft tissue inflammation or bone inflammation. There in the wipe, everything around the heel Achilles tendon insertion is counted, including bursitis, and then we did a more granular method where we separated it, and that's of course more interesting to do, but it's again, so we don't know, I would say, but it may or may not.
Mikkel, just a question in terms of the scores for bone inflammation, for bone marrow edema. Do you differentiate, I think, for example, presence, absence, and what about the intensity? Some areas may have more intensity of bone marrow edema than other areas, and this is very subjective.
Yes.
And technique dependent.
Yeah, so Marie, if you want to answer, then you can speak up, but I can take this and but it's, you could say that what we do is to measure there is definitions, and it says that you should assess the area which is within 1 centimeter of the insertion of an incisus, and that was what Maria or I showed, a line drawing of one of the regions and that's the intention. Within that area, it's dependent on how much space is taken up. Is it 0, less than a third, 1/3 to 2/3, or 2/3 and above? And then it is based on volume, not on intensity. And of course, that's not, you could say, it can definitely be discussed. And what we have said is that if it's close to the border between two grades, then the intensity can influence the scoring. But it's a vague wording. But generally, it's a question of that we have chosen to do it based on the volume rather than the intensity.
It's an old problem, Andrea, that we faced, I think, across every scoring system, and because of windowing and a whole lot of other things that we worry about it.
Mm-hmm. Okay.
I just had a question. The BML scores were quite poor for both systems, and very poor for HIMRIS. And I was curious, I may have missed it early in the presentation there, but was there a lot of BML? Like, what was the sort of the relation of the amount of BML to the scoring range available? Were these patients with hardly any or lots?
If you look at the scoring ranges, they are very small for HIMRIS especially. So I think the patients, they had only very little bone marrow edema. Yeah.
Okay, so that helps to understand then, because if there's very little pathology, then the sort of noise of the red marrow that we see in the femoral necks and femoral heads and acetabulum would definitely interfere more. That helps to understand it a bit.
But there were actually some effusion changes, and I think that's why the HIMRIS effusion performs well. So
yeah, there's more signal to compensate for that. The signal to noise ratio is higher with the effusion, then, isn't it? There's more real pathology there.
But it definitely reflects what you're saying, and it's of course important to know that you could say having a systemic disease like a inflammatory arthritis, these patients were not selected but based on they were undergoing treatment in exercise 4, but they were not selected based on having anything in the knee or the hip, and therefore some of them had very little, and that will be, you could say, an issue if the inclusion criterion is that you have axial SPA, then it will not be as much happening as if you have a hip OA. So it's a very different range of scores on the average in a PSA patient and in a hip OA patient. So we have to work with that, how that should be done. And then we couldn't select a number. We didn't have enormous amounts of images, unfortunately, of these patients, which were truly whole body MRI images, which we required. That we didn't want to have very good quality images from dedicated MRI because then we thought we would be cheating, you'd say.
Mikkel, it's Rob Lambert. As you're aware, when we were developing the Spark scoring systems for bone marrow edema in the spine and SI joints, we discovered that including a component of intensity in the scoring system contributed to the responsiveness of the system. And it's one of the aspects of it that in fact has resulted in many people now using these scoring systems in preference to other systems that don't include that. So I would say here at this stage of our development of a whole body system, we should not at this stage include intensity because the whole process is still in evolution. There's a lot still to be developed. And the intensity is the component that is more dependent upon the type of acquisition, exactly how you do it, and the degree of fat suppression and the degree of T2 weighting, etc. But I think in future years, as it evolves and it becomes more refined, we may wish to revert to including some component of intensity, as it may eventually be useful in assessing responsiveness.
Yeah, maybe even just mild and severe.
Yes.
Like
that's all we did in the Spark.
You know? Yeah.
Yep.
Yeah. No, but I agree, and there is a challenge in also this is if you were doing the optimal hip psoriatic arthritis scoring system, then you could say also go into some even more detail and the thing is what should be done when you're assessing. The principle is that you should assess the entire body, but I fully agree with what you're saying. Right. More comments or from anybody to any of us?
I've got a comment from Marie around sort of trying to somehow formalize expertise of readers. And so you have quite a large range of inter-observer ICC data there. And I wonder whether you've looked at that or whether it'd be worthwhile to look at that more formally in terms of how people, for example, use the RETIC module to calibrate before they actually did the reading exercise, you know, reader expertise, because I think it would be helpful to understand why we do have this quite substantial range of ICC data.
Yeah, I agree. We have to look more into that. But yeah, I think most of us did the retic modules, but of course we will have to find out how to look at the data. We just choose this to look at the 3 best readers from the previous exercise. But you could, of course, you can do it different ways, and you will have to look into to who completed the retic modules and things like that.
Yeah, there's always someone has to graduate at the bottom of their class.
That's true. That's true.
So I have a question. This is Michael Bosen from Copenhagen.
Yes.
Have you calculated, for instance, another agreement parameters like limits of agreement? Since I understand that the bone marrow lesions, they were only in the lower end, so that would be, so when you have a very homogeneous score around a few points, then your ICC will suffer severely compared to when you have a big variation between 0 and a lot. So it's just a matter of seeing how bad the data really is, because the ICC might not make the data any favor here because of the low variation in the scores.
I think it's an excellent point, Michael, and it kind of potentially brings in folks like Dorcas to tell us, when we're reporting imaging data, what are the metrics that we should be reporting? We tend to focus on ICC,
sure,
but there's also smallest detectable change and limits of agreement. And I think maybe we ought to be standardizing so that our data is presented in a pre-specified manner.
Yeah, thanks, Walter. And I would agree. I mean, the ICC is a great statistic, and that was really well presented. And then, yes, going into some boundaries of error or an SDM, trying to get some sort of putting it back in the scale score of how much is the boundary of error around that, around any measurement of status or of change would be a great idea.
I gotta say that it's a real big issue, because for ICC in particular, when we're looking at change in scores, the change scores are always small, so the range is always small.
Right.
Exactly. Yeah.
Most people interpret a low ICC as, oh, you got bad agreement, versus ICC doesn't reliably measure agreement under those circumstances. The reality of it, and talking to clients is very, very hard, because you tell them, well, we take the baseline where we got a big spread, we look at ICC there, and if the score is from 0 to 1,000 and we both picked 100 away from each other, that's fantastic. But if the score is 0 to 3 and change, I picked a 2, she picked a 1, we've got terrible agreement, but we're much better than we were in the other scenario. So this can be very confusing for clients, and we lack a good way. You see, all of our studies use ICCs, right? All of the OMERACT studies. We really lack a good way of getting at a change measurement, maybe besides SRM.
And that's maybe one thing that we could work on together is how to really use all the experiences that you have with these really challenging ICCs and figuring out the best way to depict the data. Pulling Martin Boers in there too, he'd probably say to plot the data and just allow people to see the data. And then something with PROs or measures that I'm working with, we always try to make sure that the homogeneity, heterogeneity, and the sampling is what you're expected to see in a trial. Because if you are expecting to see that very homogeneous type of distribution, then you've got to achieve your ICC in that distribution, because that's going to be your reality in the trial.
I think cumulative probability plot data is a simple way of illustrating, particularly for change data, for illustrating the measurement error, because you see that immediately on both ends of the curve. And so I think being able to, and that also tells you something about the degree of change and its distribution. And so I think that one of the essential metrics that we need to see for imaging data is cumulative probability plot data for change.
Yeah, but the only problem with that is it's a visual. It's just, there's no conversation.
Yeah.
It's just, here it is. And well, what is it? And you can't describe, well, what do you mean describe? Take a look at it. And it's hard to say, well, that's worse or better, but by how much? And so we're still missing a metric there that's usable for the context that we have to use them in.
Yeah,
Try to avoid
it could be,
as a way I get
exactly.
Mikhail,
it could be small.
I think that
Mikhail,
Marisa has a question, right?
Marissa, is that what you said, Mikhail?
Yes, that was what I said, actually.
Hi, Mikhail. Hi, everyone. You may remember that we used to report both a SDC as well as ICC many years ago for most of the MRI reliability studies, including graphing the data. So it would not be that difficult to go back to some of those earlier papers and use the methods that had been done back there with these, because what everyone is saying is quite correct. When you don't have that much change and you don't in that bone marrow lesions, you're going to get falsely low ICCs. And so one should always be using the two complementary reliability methods, an ICC and the Blandin-Altman type limits of agreement method.
Yeah, we do routinely do ICC and SDC with the SDC on the change end of things.
No, but well, I would agree. It's very good. It's very good recommendations, and you agree well, and it is correct. The challenge here, which makes also some of the things difficult, is that we did not have a material of let's say 30 knees which were actually inflamed at the beginning, and then we treated them, and then they were going down. That is the challenge, in contrast to what we could do with RA in the older days. But it's still very relevant that, and we will work with that also to get different things than just ICCs in. That's for sure.
And the smaller the range, the better the SDC.
Wow.
Exactly the other way.
Is there ever a decision point when you feel that the ICCs or whatever form of the reliability you're looking at, because they're related, where it's just too low? So you're going to set aside that approach? Like in some of them, Marie, that you were showing, I was thinking, oh.
And we've used percentage exact agreement and percentage close agreement, which is also valid stats for telling part of the story. So you've got to be careful, not only the distribution of what you're measuring, but understanding, have you trained your readers properly? So I think there's a range, and I think at least Marta has talked about this issue too, Dorcas, as a follow-on from the workshop. I mean, it would be lovely if OMERACT produced a definitive piece on this, on how to do appropriate reliability stats, because everybody struggles with it, and 3 out of 4 reviewers at any journal will give you a different answer. It's
and the trust
really
one doesn't work so well. Trust me.
No, but it's a great area for us to play in.
But is it would you leave a tool behind or an imaging technique behind because it just doesn't achieve your reliability?
I would. And one of my questions to some of the earlier work when we come to the wrap up, this is a nice segue, was actually, are there things we should be dropping that it's really hard to get good reliability on?
But there's what,
and we have.
Yeah.
Yeah, but one thing that should be remembered is that this is not the intention that we should have an SBA hip assessment tool by itself. Because it would be something like that we wanted to do a joint count in 3 joints and then look at the assessment of that. That is not the intention. It's the whole overall score that we use, and then we are trying to find out where are the weaknesses, what can we do in order to have the
but that's a particular whole body issue, whereas we're talking just generally in our field, we need something about reliability. And yes, as I think it was Charles chimed in then, that we have dropped bits out of our previous scores where they weren't reliable, and we realised they just weren't going to be good tools, Dorcas. So I think it's very important, and I think everyone would buy into that.
I don't think you can make any judgment based on what we've seen today. For the simple reason that some of these, particularly in the fourth exercise, there was very, very little BML.
Okay.
Okay, Philip, perhaps you should see which we should have a few minutes for discussing also where we should go.
And
we are actually
I'm not sure if we're going to get just everything drops out in 3 minutes, although Sean is on still, so that's always a good sign that you won't kick us off immediately at the end. Okay, where to next is what I'd say. So where to next, let's do it in area roughly that we've presented tonight. Where to next in OA? So number of different areas. Do the hand OA people want to talk about where they want to go next? Nope. The knee OA people or hip people. I think Walter and Jacob, you've got an idea, a good idea of where you want to go next.
Oh yes, I think Jacob actually touched on it with the very last slide with the artificial intelligence. Jacob, you still there?
Yeah. I think. Oh, carry on, Walter. Yeah.
No, well, it was around the use of artificial intelligence to apply the overlays and to automate this application of the overlay and the expansion of the scoring to agree to in the setting of more BML and diffusion. So we've got to find the right sort of cohort of patients to evaluate. Much of what we're seeing right now is demonstrating very little change. So we need access to more scans so that we can test discrimination. That's where we're getting good reliability, but we don't have an opportunity to test discrimination. So automation and discrimination are the things we need to focus on.
You may, I'm just interested in the terminology you'll use going forward, not a big thing at all, but this will be AI or ML assisted scoring rather than full ML scoring. It's just, that's the sort of zone you'll be in.
Yeah, I can comment on that because essentially, you know, the artificial intelligence is going to help make it less tedious, make it faster. But it really, as we've seen from the work on the effusion so far, the eye of a human expert in this is still at this point irreplaceable yet. So, you know, to really do really good scoring, really high quality scoring, still needs the human expert to supervise. But it's a lot easier for an expert to just supervise than to do the whole thing themselves.
I must say, although I'm not paraphrasing your terms there, but I am still a believer that supervised ML methods will take us much quicker to where we want to go than the sort of throw all the white dots in together and read a picture. I think we're a fair way away from that, providing us with a useful tool yet. Ida, you've come back. I just wanted to talk about hand OA in the future and where it's going to go.
Yeah.
Imaging wise.
Yeah, yes, I understand. First, I think it would be nice to have this published, the results that we have, you know, the exercises we have done so far. As a next step, maybe we could look at the sensitivity to change. I don't remember exactly, but maybe Feline did some work when we worked on the TOMS system. But I think we could. I think we need more data to look at the sensitivity to change. So we are planning.
You mean you need more data sets? I suspect. Is that correct?
Yes, we are planning a study in Oslo, but it will take time before we have the images.
Yeah. And Dorcas, just to reiterate some of the comments said earlier, it is an issue sometimes is getting a data set with a spread of change, as well as a range of pathology, but a spread of change as well is an issue.
Yep.
Feline,
And you're not alone in that. A lot of groups have that. Worker productivity is having a challenge with that too. So.
Feline, are you still on? I can't see you at present. Oh, yes, you are. I see.
Yeah. I want to add that we did a clinical trial in Leiden with patients with hand osteoarthritis, and we also have MRI. So maybe that would be a good method to look at clinical trial discrimination. So maybe we can see if we can do something with that.
Yes. So do you mean the HOPE trial, the prednisolone trial? Yes.
Yeah.
And so, Feline, of course, as always, the way we've got around sensitivities about people's personal trials and everything is trying to take subsets out, and that way, so that there's no conflict for you with your own trial, etc.
Yeah, that would be good.
Which is important, how we should manage things.
Yeah.
All right, so I'm trying to step back each time and saying, well, we've got some scoring methods in hand and knee. The real problem is demonstrating change because there are very few effective therapies in OA, and that leaves us with a real problem developing systems. I'm just watching the time tick on. What about on the whole body front? First of all, there's a okay, somebody needs to mute. Somebody's having way too much fun. Whole body, where's it going to go? We've seen already. It is a macro picture.
Can I say one thing?
Oh, sorry, Marie,
yeah,
please.
Because of course we want to make this imaging, this reference images atlas complete, because we are almost there. So I think that will improve the WIPE method to have such images.
Can everybody mute their microphone if they're not speaking, please?
And
thanks.
of course, we would like to have more appropriate data sets for future clinical trials, but yeah.
So the point of this atlas is to help the training phase, because we've got to be careful. Exactly. I think the Ramrus atlas went out when we had quite an evolved, reliable system. This one is really to help evolve the system. We've got to be careful of how we're using it, and that does remain an issue, because these have been very hard to score, and we won't go into all that.
Everybody, do you think the application of this would be in patient selection for clinical trials and epidemiological studies, etc., or actually for monitoring disease progression and treatment response, or both, and competing against, say, SAMRIS of the hands? What do you think? Because doing both, that won't happen for 20 years just because of budgets. But where is its niche?
Yeah, Mikko?
I think that you could say that particularly in psoriatic arthritis, I think that it could be a valuable outcome measure for assessing overall inflammation. But of course, we don't know, because there isn't any psoriatic arthritis trials that we've been evaluated with the system. But you could say that particularly psoriatic arthritis do have a lot of inflammation in different regions, both small and larger joints, and in axial and peripheral entices, and therefore it would be very well suited for that, I think. And it's a challenge also now that the outcome measures in psoriatic arthritis are not that fantastic. In SPA, actual SPA, it's fine. There's good methods now, but in PSA there is a problem, and also because you can say you have to use almost only study those patients that do have small joint synovitis, because then you have sufficient amount of swollen joints that you can actually assess a change in, and it would be much more interesting. So you restrict your trials to a limited proportion of the psoriatic arthritis patients. So I think that would be the optimal a really interesting area, and I'm sure that the quality of images will increase steadily over time. The challenge is that we have to live with these not too optimal image materials, which are several years old before we can get access to them, and thereby our results become not always.
I remember back 15 years ago or so, BMS and some of those very early PSA studies did want to look at patient burden in different locations. And then that all fell away, and you just need to get the sentinel joints in the hands and make the case there, and then just assume it's working the same way everywhere else. And nobody's talked about those other ones. And pharmaceutical companies, I mean, you talk about it for a second, but then the budget comes in and it hones in on just the small joints. So I'm wondering how to get. I'm wondering where that will go. I think there's a role for it, and I think it could be good. I just, in the practical sense,
I must say,
worried it'll be a while before we.
I'm with Mikkel here in that I think if you can get something that captures enthesitis more, that would be useful as an outcome measure. But at present, if I would recommend to somebody, I'd probably say at present, take people with hand disease and do a SAMROS. But
so maybe it needs some epidemiological study to show whether these other joints are relevant or give you information that you can't get by just looking at the hand.
I also think that we're not going to achieve the resolution. So it is going to be a global score, which means it's going to suit the polys. On the other hand, PSA trials put in polyarthritis, so that's not a bad group to put in. Their mean tender and swollens are quite high. So I think there is possibility there. I think the diagnostic issue and the inclusion criteria is another question. It's not been a zone we played in because it's not a trial outcome, it's the trial inclusion. And there's an interesting question for OMERACT, and I like the idea of us thinking about inclusion criteria, because that's part of clinical trials, is thinking about how you include. So I'm not saying this particular method, right, but I'm saying the role of imaging.
All of my RA trials and PSA trials, maybe 3 or 4 with MRI, have inclusion criteria based on MRI.
So I think that's a really interesting topic for us to get into, actually, stuff we started doing
MRI.
That SLR on, Charles, that you owe me, that we need to talk about. But anyhow.
I think we do have to talk about large joint involvement and how we evaluate large joint involvement in clinical trials. Otherwise, we'll never make any progress on the pauci-articular variant of disease. And frankly, yes, peripheral joints are important because they're accessible. We've got some background data, but prognostically, what really matters and what matters in large joints is important. So I think we do have to advocate for whole body methods, because if we don't, as an OMERACT group, advocate for whole body methods that allow us to evaluate the large joints as well as the small joints, we will not advance the research agenda. So I think it's really important for us as a group to advocate for whole body methods when we do speak to industry, because we're not going to solve the problems that we've just raised here.
But we have to advocate by research and research data. And you know what, you're absolutely right, because you have an ACR count, but the hips are 1. 1. And if you get a hip involvement, I mean, you're really disabled in RA versus one PIP joint. And so there's a different, and they may respond differently. The whole game may be different in those patients. They're not that common, but they're really bad. So there's some stories here that we haven't really gotten into that would really advance what you're saying.
All right.
But also, it's Michael.
Yes,
Hold on. Can I just have it in order? So, Michael, then Andrea.
Yeah. It's a very interesting discussion, and I fully agree with all that's been said. But another thing that I am also struggling with is how do we deal with the soft tissue involvement in PSA and including dactylitis, because it's it's the current scoring system, let's say, to some extent take it into account if it is in the hand and we do per summaries, but it's not really assessing, and it persists for a longer time. We also see in some of the whole body trials that we're doing, do have a lot of soft tissue involvement around the ankle, for instance, in the metatarsal muscles, the lumbrical muscles that are flaring up. And this is not included in the scores, but they are detrimental for the patient because they actually are very painful, meaning how do we deal with that and include it so we also can assess it in the trials that we're doing.
So just to sum that up, is to say, even what we're looking at in whole body MR is not picking up all the relevant pathologies.
Yeah, exactly. So that's one thing. Yeah.
Andrea.
Yes, I think I'm just trying to complement that, and I just have a question for the group. If anybody uses gadolinium for whole body MRI, we don't use at SIG, but there are some people that I have seen using. There is a very heterogeneous distribution of contrast material in different joints. Is a major problem of using gadolinium in whole body MRI. And if anyone uses diffusion weighted imaging for whole body MRI, we use for cancer, but we have not used for arthropathies. So I just wanted to know, because this could be some type of techniques that could help the data acquisition and improve the detection of these points that were discussed about soft tissues and other things related to enthesitis and other findings.
Some of the whole body MRI studies we did some years ago, that means 5 or something like that, we actually did use contrast also. The problem is that it already takes quite a significant amount of time, and we ended up thinking that it was better to get some images to look at them with a bit of higher resolution than going into the T1 post-contrast. But you can't say that it's been studied well. There's also the challenge that it takes some time. It will, when you move the patient in the magnet and take the images, then you will take them at different time points depending on the region that you're doing, and thereby they will not be obtained within those 5 minutes, 5-10 minutes after contrast injection, which may be an issue. Some of them won't. And we have tried diffusion weighted imaging, but only in larger joints. I don't know any other comments. So I wouldn't recommend doing it because of the time spent as it is currently.
Mm-hmm.
But
so
it may be
the issue of better sequences, and I think we're coming from an area where the technology's been largely used for other purposes, hasn't it, Andrea? I mean, it's been largely used for screening for multiple myeloma and other things. And there hasn't been a thought of widespread inflammation detection, I think. So this would take some basic research on sequences. But many of our other areas developed because there was a drug in the area interested, and we were able to do stuff. And for PSA, companies have become, I think, PSA have become less experimental, dare I say, less caring about developing new technologies, although some particularly want to sell an enthesitis message, and they may be the ones that might help us gather some basic data sets to understand the questions that both you and Michael have raised. Mikkel, other things to you just on the whole body issue?
Well, I think that we have to think of how we can. No, I think that the majority has been covered, and we have to think within the group of how we will proceed, and also how if there are more things we should do analysis-wise with the data we have. But I think that the most important thing would actually be to have better data sets. But of course, we may not be able to get that. And then perhaps looking at percent effect agreement or close agreement as suggested by several and STCs.
Have you, just on that, have you sucked the juice, as it were, out of the Leeds data sets yet? Or were they not?
Yeah, they are in there. They are in there. So the 10 sets that were, you could say, post-contrast fats pressed T1 weighted images are from leads. But that's an option, of course. It was a challenge that we were not used to looking at the images, and they look different. So but the results were slightly poorer, but not massively poorer, and they had more incisors. Therefore, we actually chose to include them so far.
Because one of the big picture issues is how do we find people's data sets? It is interesting that most of what we do is word of mouth, isn't it? It's been word of mouth around this group of what's going on, but we've not gone sort of broadly asking for other data sets. And I don't know how we go about that. I'm open to thoughts, but it is a limitation of our group is we're limited by the data we can access.
Yeah.
Oh,
Gotta go.
Oh,
I'm sorry, I gotta go. Sorry, guys. Thank you very much.
Good morning to you.
No worries. I'll send around the summary of the discussion.
That's great.
Okay.
So, no, but
See ya.
Thank you, Paul.
Bye.
No, but I think we have to advocate, as Walter mentioned previously, so that we can get it in some clinical trials, so that we get better images. We've tried to approach, when we started out with whole body MRI, we approached quite a different number of groups who actually published something around whole body MRI, including some of the German groups, Sabine Wechbach and others who actually published the first psoriatic trial. So we tried to go around there, but there isn't that many groups that does it.
Yeah.
And I don't know how we should get hold on them, except from publication, which we have tried.
And in a trial, I mean, it's hard to recommend that. It takes up so much time. The patient burden is there. You can't do the hands in high detail and that. So you do one or the other. So now you're in an
do it as an add-on. As an add-on is really hard.
It is really hard. You could do it as eligibility. You might get away with getting at least some baseline experience in that. But
well,
again,
the way to do it, I think, is really through a phase 4. I mean, it's going to be difficult to incorporate this into a pivotal drug clinical trial design. But I think in phase 4 studies, where you're focused on specific questions around impact on treatment on weight-bearing joints, cohort studies, and particularly where perhaps we explore other things like biomarkers, those are the sorts of settings where we're going to be able to generate this data. We'll have a lot more flexibility around the inclusion criteria.
Yeah, maybe if a case is made for different patient subsets and the treatment there.
Yeah.
I haven't seen that many phase 4 studies going those sorts of directions, but that's the opportunity.
Yeah.
You'd have to solicit them. They don't come to you with those sorts of things often.
Yes.
Right.
And Dorcas, the other issue is that generally most of us have found that grant bodies are not really that interested in developing imaging biomarkers. They love seeing intervention studies and mechanistic sub-studies, but they're not so good at wanting to develop, and you'll be familiar with that across all outcome measurement, is not that sexy to many grant funders, I think.
Mm-hmm.
Okay, are there other areas? So we've talked some OA, we've talked whole body. Are there other zones that we should be coming back to think about? Yes, sorry, Dorcas.
I was wondering, I know that you were saying earlier that you don't have a patient research partner on, but I'm wondering whether they could help you with evaluating some of the things that around the burden of some of the testing. Just as we were logging on, somebody was saying that they had had an MRI and that was a lot. And I was wondering, like, how long does the whole body take? How do people tolerate the contrast? How long do they have to stay in the machine? And things like that to help you weigh that amongst all the different things you're thinking about.
I guess just, and maybe we can take this offline somewhat, but I guess none of the issues here are new, that it's basically there are people who like needles and people who don't. There are people, and time in the machine, that generally the issue is, there are some people, about up to 10% or more people have some degree of claustrophobia.
Okay.
these are well described facts. And yeah, length of time is an issue, and a whole body scan, easy an hour. So we talked about making it. We talked about making it a modular so that you would have less time effect. So I think there are a number of challenges, but I think most of the MR world, I don't think there's newbies. They're sort of established challenges for patients.
Yeah, the patient burden is pretty, I mean, there have been hundreds of millions of MRIs being done, and they don't care why you're getting the MRI. It's the time in the magnet and whether you get a needle. That's basic.
I have a comment on this. This is Michael. So how do we deal with the emerging new technologies like dual energy CT scans that now can look at bone marrow edema, for instance, to enhance our trials? It's faster, it's better, it's good for the bone changes, especially now. So wouldn't it be, since this group has been doing so much great work within the MRI realm, that we are, now that this, especially spectral CT and dual energy CT, are emerging technologies that are beginning to take territory where MRI usually was the, let's say, the turf champion, and have an idea of how we should address this, and how we should maybe include it or complement what we have done already, because especially for the bone and the bony changes, the CT is superior in all sense. It's 3D, it's give you a much better data set for the AI that comes. And is this wrong to have it within this group, or and also availability?
That's
which so it could complement the MRI, because it could help us to include the right patients into the trials in a faster, more efficient time, or less expensive way. And then we use the MRI where it's make more sense.
But the dual energy CT is only available in a couple of places, so it narrows down your recruitment so much. Same with HRPQ-CT, you know, there's some real power there in a few places. And so that's generalizability.
It is all
Michael, I'd have no problems about bringing that into this group, bringing CT technologies in. We might have to change the name of the group very subtly to fit it in, but I've got no problems about, you know, conceptually about tools that could be used in clinical trials. But like Charles, my understanding is at present, the rollout of those technologies is still relatively restricted. So it would not be something we could say, this is a great trials tool if it can only be done in 3 or 4 centres around the world. But I think that will change. I think that will change over the next couple of years.
It would.
Very much.
And it's changing fast.
And I think we should be thinking in that zone. If I were to go into a new technology, it'd be CT. To plan for a whole lot of reasons. So I think we should, we'll minute that sort of zone ahead for us.
Yeah, but just to plant the seed, it's actually just my,
Okay.
Interesting.
So that fits under new technologies, which is one way of thinking about it. Old technologies, is there any of the other scores we've done? I'm now brainstorming with you all, even though everyone probably wants to go to bed. Can I just ask, you know, does SAMRIS need evolution? I'm throwing it out there. Are we happy with it?
Well, I always include the wrist, every trial. And I see a lot of wrist involvement. And it's a big area. And it's a shame to toss it out the window. So I don't. And all I call it the extended SAMRIS. And so what? You got the other one there too, but I add this.
Seeing non-RAMRIS features of SAMRIS?
Say what?
Are you seeing non-RAMRIS features of SAMRIS?
Only that we include them, like tenosynovitis. Now that's part of RAMRIS, but it was always part of SAMRIS. So the tenosynovitis is in there. We have that score already. Do I see, well, you know, I don't see a sausage digit and no sausage wrists, but Charles, you know, mostly it's RAMRIS features.
Is there an exercise? Do you have access to a data set through your reading? I.e., you'd have to ask whoever the company was. But is there access to a data set, and Mikkel, is there an appetite?
As they get published, I think we can have access. There's some that are just finishing up. There's some that were finished I could look into, but yeah, the answer is we can probably get some, and I'll be able to find out whether it made it.
We have a data set of 60 patients, 40 of them with psoriasis, 10 of them with psoriasis skin changes, and 10 OA patients. And then we also have 20 normals on the same scanner without contrast and dynamic contrast enhanced MRI that we can compile. So it could serve as a good reference reading, and it also includes the risk. And I fully agree with you, Charles. I see a lot of wrist involvement. And also for rheumatoid arthritis, I see a lot of involvement in the IP joint, even though
DIP.
Yeah. So and it's not there. It's not in the score. And if you have a severe inflammation in the thumb, well, why not include it?
Are they treated, Mikael? Are they treated with some specific drug so that we can look for a responsiveness?
No, unfortunately not, because this is a cross-sectional study where we compare some new video capillary scope and laser techniques with some high-resolution ultrasound and cone beam CT.
But you can still get the prevalence.
Exactly. So we have at least something where we can see whether it makes sense to include it.
I must say the only thing I'd want to do now would be a SAMRS, extended SAMRS responsiveness paper. That sounds like a useful addition to our.
And if nothing, even in that first data set, it would take a second to go through and count how many of those wrists are positive over the number of patients. So the prevalence is what, 20%, 30%, you know, that would be a good number to know.
Guys,
I can tell you already.
The whole body trials as well. Yeah, we know from the whole body trials as well how many have wrist involvement.
It's getting near the hour, which people tell me is 2 hours on straight on one of these meetings drives most people to despair. And I'm worrying, I'm looking in everybody's eyes to see if they're despairing yet. But so final comments from anybody. I think that was a helpful last discussion on a couple of areas that I'll make sure we add to Paul's summary of the meeting. Any other zones? Anything else that people want to bring up? If not, over to you, Mikkel, to wind out.
Thank you for including me.
Pleasure.
This is Michael.
Work with you.
Okay, well, in that case, everybody, thank you so much for being part of it in a virtual way.
Thank you for staying for half an hour.
Don't get the beer afterwards, sorry.
You too.
It was fun, as usual.
Thank you.
Cheers.
Thanks,
Good
guys.
to see everybody.
Bye. Bye.